Hello, my name is Kathleen Lisson, and this presentation is on infection in patients with lymphatic disease. I am so grateful to my friend Peggy who allowed me to share this picture of her wedding day with you. It illustrates two important concepts, one from venous medicine and the other from lymphatic medicine. The venous medicine concept comes to us from Dr. Caprini. Never treat a stranger, never kill a friend. And this encourages you to get to know your patients. And from the lymphatic side, lymphedema doesn't take a day off, so neither can you. And this is illustrated by Peggy having that compression garment, that blue compression garment on her leg, even on her wedding day. So my name is Kathleen Lisson. I am a board certified in therapeutic massage and bodywork. I'm a lymphedema therapist, and I'm the author of Stress Reduction for Lymphedema. We're going to cover several topics today. First, we're going to talk about a little bit about compression, and then what is not an infection. Some effects from wearing compression can be mistaken, especially by the patient, for an infection. So let's look at some of the symptoms. We'll also look at colonization versus systemic infection in venous leg ulcers. It's important to try to keep the compression on as much as possible because it has a positive effect on that patient. Also, we'll look at the infections that are the emergencies in lymphedema: erysipelas, cellulitis. In filariasis and podoconiosis, it's called ADL or ADLA. We'll look at lymphorrhea, and we'll see how compression bandaging with short stretch bandaging can really help with lymphorrhea, which is when lymphatic fluid exits through the skin. And then we'll also take a brief look at the effect of lymphedema on knee surgery. So as I alluded to before, nothing is really an emergency with lymphedema other than infections. We're seeing mostly conservative treatment for lymphedema. We do also have surgery. We'll talk a little bit about that during the presentation, but most conservative treatment is the majority of what we're doing to treat patients with lymphedema. But infections are the time when they really have to act fast. They have to go to the emergency room, get that clinical diagnosis, start taking those antibiotics. The first use of compression therapy is thought to be by Hippocrates roughly 2,500 years ago to treat the sequelae of venous insufficiency. So compression has been around for a long time. Fast forward to the present day, and we'll move from Greece to Italy to a document that is lodged in the government of Italy, multi-specialty recommendations for the appropriate and affordable lower limb vein lymphatic disorders management. The authors are saying in Good Clinical Practice Statement number 8, it is appropriate that graduated compression for discomfort of the lower limb due to venous and or lymphatic disorder be prescribed by an experienced healthcare professional. So compression around a long time, effective where it's used properly, and should be overseen, prescribed by the experienced healthcare professional. We have a variety of options for medical compression stockings, compression bandages, so the short stretch bandaging, adjustable compression wraps, the inelastic compression, sometimes called Velcro wraps, and thromboprophylactic stockings. So what is not necessarily an infection? Some of the side effects of just wearing a compression garment around the skin. They can include skin irritation, itching, cold or warmth when wearing, and dry skin. It's important to have that conversation with the patient, see if there's something that we can do to help their experience, but these are not necessarily infections. Medical compression stockings may have more of these symptoms than thromboprophylactic stockings, maybe due to increased venous congestion. That's according to the researchers. You can also see allergic skin reactions or what someone thinks may be an allergic skin reaction. Is it a true allergy, or is it due to the occlusive barrier effect of the compression material? And we hear all too often the compression garment, oh, it's too tight. But is it actually too tight? Is it incorrect sizing or prescription? Or is it just a new sensation of pressure for the patient? And the researchers state it may take several days before patients actually get used to wearing the compression. In my experience as a lymphedema therapist, it also may take several washings of the garment. And also, if the washings and still the day of wearing and they're still complaining about the prescription, have them put the garment on in front of you, in front of your eyes while you're looking. Make sure that they're applying the garment correctly, even if they've had that garment before, even if they've been wearing garments for a long time. There can, however, be a risk of toe infection. The occlusive barrier effect of compression devices in the toe area, so these closed toe stockings, may add to the risk of infection, which may be mitigated by having toe-free compression. So having that open toe stocking may be an alternative if someone has a high risk of toe infection. So let's talk about colonization versus systemic infection. Systemic infection. Bacterial colonization of the skin in chronic venous leg ulcers is common, and in the absence of clinical signs of systemic infections, it's often treated with topical antiseptics, dedicated dressings, and necrotic tissue debridement. Medical compression with venous leg ulcer wound colonization. Say yes to the compression. The evidence strongly supports the use of medical compression for venous leg ulcer treatment in patients with that local bacterial wound colonization. There's no evidence that compression may worsen the bacterial colonization or the infection. And compression can be combined with wound care. An application of compression together with local wound treatment facilitates and accelerates the wound healing in the clinical settings. Studies have shown that restricting the use of medical compression in venous leg ulcer treatments leads to prolonged ulcer healing, which is not what we want. And there's no evidence that compression principally increases the risk of infection. To the contrary, say the researchers, compression may facilitate healing in conditions such as erysipelas and lymphedema or in venous leg ulcers, despite the bacterial colonization. They suggest additional compression in leg erysipelas or cellulitis to reduce inflammation, pain, and edema. In infectious inflammation, they suggest compression only in combination with antibacterial treatment. So let's talk about compression after the venous leg ulcer. The ulcer has healed. Does the patient still have to wear the compression garment? Researchers showed that compression significantly reduced ulcer recurrence at 6 months. It's important to talk about the importance of keeping that compression on after a patient has a venous leg ulcer. And include the lymphedema expert in your venous leg ulcer treatment. Ulcers rarely fail to heal because of the wound alone. The underlying lymphatic system is also overwhelmed. Venous hypertension can increase the lymphatic load, and lymphedema management is needed to reduce edema, inflammation, and tissue fibrosis. You see this very American picture of a handshake, and think of that concept of teamwork when you are helping patients with venous leg ulcers. So let's talk about cellulitis. This is the infection that we're concerned about as lymphedema therapists. It's a clinical diagnosis, and I have an interesting piece of media for you. This is AI generated, and it is generated by and posted by patients with primary lymphedema themselves. There's a social media group called LymphyStrong in America, and they're spreading information. They're trying to increase awareness to fellow patients with lymphedema to help them recognize the signs and symptoms. So let's talk about cellulitis and lymphedema and phlebolymphodema. So the incidence of cellulitis associated with lymphatic diseases varies by the etiology of the lymphatic disease. Interestingly, phlebolymphodema has the highest rates of both initial cellulitis episodes and recurrent cellulitis events. And phlebolymphodema is one of the largest cellulitis-related total costs per patient per year. Researchers recommend that prevention as well as early identification and treatment of phlebolymphedema-associated cellulitis could significantly decrease healthcare costs and improve patient quality of life. So let's get a little bit specific with our definitions. Especially in America, we use erysipelas and cellulitis interchangeably. Officially, erysipelas is affecting the superficial skin layers, while cellulitis involves the subcutaneous tissue. Compression therapy can be safely used in patients with erysipelas. Edema can be reduced by compression therapy, which can reduce complications. Compression may also improve the penetration of the antibiotics into the inflamed tissue. This is a good argument for continuing wearing compression when the patient has this erysipelas cellulitis episode. Let's look at more facts related to cellulitis. 92% of lymphedema-related hospitalizations are linked to cellulitis. Non-purulent cellulitis presents as erythema, warmth, edema, and pain, often without fever. Antimicrobials like penicillin and erythromycin treat cellulitis and lymphangitis. The most significant risk factor for recurrent erysipelas and cellulitis is lymphedema, and each cellulitis episode causes further lymphatic damage, increasing the infection risk in a vicious cycle. Further lymphatic damage, further fibrosis. We need to stop and heavily reduce the incidence of cellulitis in this population. And one thing that can happen is the surgery for lymphedema. Lymphedema liposuction and controlled compression therapy significantly reduce the risk for erysipelas and lower extremity lymphedema. We can see our colleague Hyder here. Here is him after he did an operation helping someone reduce their tissue in lymphedema. This is going to reduce the risk of their future episodes of cellulitis. It is not going to give them a beautiful leg. This is not a cosmetic operation. And let's take a closer look at what is actually removed from lymphedema surgery versus cosmetic liposuction. And this is image courtesy of Dr. Jay Granzow, who practiced in Florida in the USA. On the left, you can see the aspirate from cosmetic liposuction. On the right, the SAPL surgery, suction-associated protein lipectomy surgery. The aspirate is radically different because what is inside that leg is not the same tissue. If you want more information about cellulitis, this is a great YouTube video on cellulitis, erysipelas, and pediatric and primary lymphedema if you want to take a deep dive on the specifics of cellulitis. And let's look at lymphorrhea briefly. This is a really great video. If you point your phone at this and open up, you'll see the reel shared by our colleague from Mexico, the lymphologist, and he shows you that compression can give really big results if the client has lymphorrhea. Let's talk about filariasis briefly. Filariasis is caused by a nematode worm. It's transmitted by multiple mosquito bites in areas which are endemic for this disease. And in this disease, the ADL or ADLA, filarial lymphedema, is the infection that they're really concerned about. A higher grade of filarial lymphedema means more risk of acute ADL attacks. Symptoms include sudden fever, chills, severe pain, and localized limb inflammation. If you want to take a deeper dive on filarial fever, this is a really great YouTube video to learn more about that. And for lymphatic filariasis-related lymphedema, integrative medicine, including compression therapy, yoga, Ayurveda, and topical creams, has demonstrated success in reducing volume, improving quality of life, and decreasing cellulitis episodes. And here is an image of me using Indian manual lymphatic drainage on a patient that has filarial lymphedema at the IAD clinic in Kasaragod, Kerala, in India. So let's talk about podoconiosis. It causes lymphedema and it affects the bare foot. It's likely caused by long-term exposure to red clay soil derived from volcanic rock in rural highland areas in part of Africa. And the reported frequency of these ADL episodes, this infection in lymphedema patients with podoconiosis, is much more frequent than that of lymphedema secondary to lymphatic filariasis. So it's an even larger problem in podoconiosis. And the podoconiosis also differs from filariasis in terms of vascular abnormalities. While filariasis shows dilated and tortuous lymphatics, in stage 3 to 5 podoconiosis, the lymphatics are actually reduced. The blood vessels are dilated, increased, and often show a sclerotic wall. So let's finish off by sharing a little bit of information about lymphedema after knee surgery, total knee arthroplasty, preoperative lymphedema. So if the patient goes into their TKA surgery with a lymphedema, it's associated with an increased 90-day rates of periprosthetic joint infection, superficial surgical site infections, wound complications, and pulmonary embolism after this operation. So if you have a patient that has lymphedema and they're going in for this knee surgery, this joint replacement surgery, make them understand that they're at higher risk for side effects, for potential complications. And I'd like to close with some advice from my fellow lymphedema therapists. I asked on my Facebook group to my Egyptian lymphedema therapists, what messages do you want to give to your colleagues in the venous world? We want you to understand that lymphedema is a chronic disease. We can't provide a cure, but lymphedema patients deserve a better quality of life. Compression stockings alone are not the lymphatic care that our patients deserve. They need more than just stockings. Recurring cellulitis compromises lymphatic flow, and after infection control, the patient needs ongoing lymphatic care. Diuretics alone and diuretics as a medicine are not lymphatic care. And by working together, venous and lymphatic caregivers can close low pools of care. Think of earlier, that very American image that I shared with you of the handshake. We want to work hand in hand with you to help your patients improve their quality of life, improve their health. I'd like to invite you to learn more about compression from the International Compression Club. And I'd like to thank you for watching this presentation. If you have any questions for me, I can be reached on Instagram at Stress Reduction for Lymphedema, and my website is KathleenHelenLisson.com. And here are my resources. Thank you very much and have a great day. And if you want to take a deeper dive on venous leg ulcer and compression research that I didn't have a chance to share today, these are right here.